Good morning. Today we're going to review cardiac conditions in pregnancy and postpartum. So in this video presentation, we will talk about the hemodynamic changes in pregnancy and postpartum, magnesium sulfate and how it affects the heart, metoprolol, mitral valve stenosis, cardiac valve replacement, cardiomyopathy, digoxin, supraventricular tachycardia, or SVT, and systemic lupus erythematosus, or lupus. So starting off, our hemodynamic changes in pregnancy, we have a cardiac output that increases anywhere from 30 to 50%. There's an increased systemic vascular resistance, physiologic anemia, and the pregnant woman is in a hypercoagulable state. Postpartum, there's a lot more details that I put in here because it's a shorter period of time where a lot of things are happening. So within 10 minutes after the birth, I thought this was pretty incredible. Cardiac output actually increases by 59%, so a little bit more than what's taking place during the pregnancy. Stroke volume increases by 71%. And then it declines steadily over the months following the birth. A blood pressure of a postpartum patient will peak 3 to 6 days postpartum and should return to their baseline by about 14 days. There's a period of diuresis that happens. So your atrial natriuretic peptide, ANP, is 1.5 times higher in the first week postpartum. And the ANP, I had to go back into my brain and say, what is that? It works to reduce blood volume by telling your kidneys to excrete more urine, which can lead to diuresis. Next up, we have mitral valve stenosis. There's lots of fun facts here. So mitral valve stenosis is usually caused by a rheumatic fever. It is poorly tolerated in pregnancy, which you can imagine if your cardiac output is increasing, your heart rate is increasing, there's all this stress on the body and the heart, and you have a valve that is not functioning properly to allow the blood to pump, it would cause a significant amount of stress. Many women and birthing people can be asymptomatic until they're pregnant, until pregnancy. They may not even know that they have this until they start feeling symptoms. They go to the doctor sends them to the cardiologist, and then come to find out they have stenosis. So during pregnancy and with mitral valve stenosis, your heart rate increases, which also leads to your diastolic filling time decreased. So there's less of a turnaround time of the relaxation of the muscles, filling of the blood, pumping of the heart, and that sort of thing. And that can lead to an increased pulmonary hypertension and venous congestion. These people are at risk for arrhythmias, both atrial fibrillation, or AFib, and supraventricular tachycardia, or SVT. There are fetal implications, including fetal growth restriction, low birth weight, and preterm birth. And the treatment or management of this condition includes echocardiogram once per trimester. We would manage these patients with medication, including metoprolol or propranolol, diltiazem. Diuretics may be used, although the research was split on its efficacy, and surgical intervention is a last resort. We don't really like to operate on pregnant people unless we absolutely have to. So that brings us to our next slide, which is valve replacements. And ideally, in what I like to call rainbow land, the patient would have the valve replacement prior to the pregnancy, although that is not always the case. The patient can have a mechanical or bioprosthetic valve, and it is important to know the difference as part of our assessment. If we know there's a patient with a cardiac valve, we want to know what type of valve. And with these patients, it's really important to think that they're at risk for clot formation. So our treatment and management would be anticoagulation therapy. And heparin or Lovenox do not cross the placenta and therefore are generally well received as a safe medication to take throughout the pregnancy. It may or may not be recommended that they stop it at a certain gestation, perhaps 36 weeks or greater, but that depends on the OB in consultation with the cardiologist and maternal fetal medicine. That's a decision that the medical team will make with the patient. Mechanical valves do better with Coumadin in studies, which I thought was interesting, although Coumadin does cross the placenta. So those are those conversations that need to happen with the patient so that they can make their informed decisions, right? They can make the best choice for them and their baby with their risks versus benefits. Antibiotic prophylaxis is recommended if there's a history of infectious endocarditis or suspected infection like chorioamnionitis or triple I or C-section delivery. So next up on our list, we have cardiomyopathy. And I tried to break this down into who, what, and why to make a little bit more sense of it. So what is it? It's basically a disease of the heart muscle resulting in failure. And there's several different kinds that we'll get into in a minute. Why does this happen? The actual cause is unknown, but it's thought to have potentially a few different causes: viral, autoimmune, inflammatory, which all generally make sense. Abnormal apoptosis. So apoptosis is a bodily function of cell death where the body rids itself of cells that are either dysfunctional or mutated. So in the event of abnormal apoptosis, the body would be ridding itself of cells that are normal and functional, which can lead to then dysfunction of organs, hence cardiomyopathy. There's thought to maybe be a genetic link and excessive prolactin levels. So all of those very interesting potential causes for cardiomyopathy. Now, who is or can be affected by this? People greater than 30 years old, multiparous pregnant patients, twins or multiple pregnancies, race can be a factor, and hypertensive disorders in pregnancy. So all of that stands to reason. If there's hypertension, the heart is not functioning properly, so that makes sense. Now there's dilated cardiomyopathy, where you can see here at the bottom in the middle, the ventricular dilation, that ventricle is almost enlarged. The muscle fibers are stretched out. And then on the right-hand side, there's the hypertrophic cardiomyopathy, where the cardiac muscle, the wall muscle, is thickening, which then almost shrinks the ventricle. So very, very interesting, very fascinating process. There was so much information about cardiomyopathy that I had to make 2 pages for it. So the treatment and management of cardiomyopathy, diuretics being one. We don't want to fluid overload these patients. That can cause some serious side effects. Beta blockers, vasodilators, inotropic agents, which will alter the force of the muscular contraction. So all very interesting pharmacology there, trying to do the best by these patients. Approximately 30% of women will fully recover, and the remaining 70% will have varied levels of residual effects after the pregnancy. The cardiomyopathy will still affect them down the road. And a vaginal birth for these patients is generally well tolerated, but of course they require some very close monitoring and very precise assessments to ensure that we catch anything potentially going wrong sooner rather than later. Next up, we have supraventricular tachycardia, or SVT. There's a lot of information here, so let's dive in. The causes of SVT, physical or psychological stress. Hello, labor, right? Labor is exactly that, a physical and a psychological stress. That's why we see this very often in labor. Hypoxia, hypokalemia, excessive caffeine, nicotine, other stimulants, rheumatic heart disease, coronary artery disease, MI, mitral valve prolapse, DIG toxicity, and respiratory failure. Treatment, if we notice this on EKG, vagal maneuvers would be our first line of action. It resolves SVT in about 25% of cases. If conversion doesn't happen within 1 to 2 minutes, we want to move on. We don't want to keep doing the same thing if it's not working, right? So our next plan of action would be adenosine, 12 milligrams IV, followed by a flush. Given caution with asthmatic patients because it can lead to bronchospasm. So that would be a discussion with the provider at the bedside to make those decisions. And they may need a calcium channel blocker or a beta blocker for maintenance long term, or at least to get them through the labor process. If the rhythm doesn't convert after those two treatments, there may be another underlying cardiac issue. There may be bigger problems. So we would need to seek cardiology consultation at that point in time. So lupus is our next condition, systemic lupus erythematosus. I hope I'm saying that correct. Ideally, SLE should be controlled for 6 months on medications prior to conception. That was what I found in the literature. But again, we know that things happen, and that's not always the case. But I did find this quote here. Active SLE is a strong predictor of adverse maternal and obstetrical outcomes. So uncontrolled lupus and pregnancy don't exactly play well together. So there are maternal risks with this disorder, including preterm labor, unplanned cesarean section, fetal growth restrictions, preeclampsia and eclampsia. And one study I found, it was 16 to 30% higher in SLE compared to 4.6% of the general population. So that's about 4 to 5 times greater chance of contracting pre-E and eclampsia as opposed to the general population. They're at risk for clots, thrombosis, infections are higher risk, thrombocytopenia, and hemorrhage. So with SLE, there are some fetal and newborn risks, one of them being growth restriction or low birth weights. In 10 to 30% of babies who are born to moms with SLE compared to 10% of the overall population. There is neonatal lupus, which can be cutaneous in the skin, hematologic in the blood, hepatic in the liver, and cardiac, which is the most serious. Thankfully, it is less than 3% of that population, so it is rare, but dangerous nonetheless. It can lead to a congenital complete heart block, which is an interference of the electrical nerve impulses. So as you can imagine, that would have serious implications for the baby when they're born. So now we're going to get into magnesium sulfate and the heart. How does it affect our heart? IV magnesium, more so than oral, slows or blocks neuromuscular and cardiac conducting system transmission and decreases smooth muscle contractility and depresses CNS, central nervous system, irritability. And that's from Simpson et al. 2021. I took that quote right out of their article because I think they summed it up better than I ever could. So that gives a general overview of how it affects our heart and our neuromuscular system. It can lead to maternal implications, decreased myocardial contractility, decreased respirations, and interference with the cardiac conduction cycle, which then leads to dysrhythmias. For our fetal newborn population, there was controversial data, so nothing was really concrete set in stone as evidence-based or best practice when it comes to fetal implications. There is a possible fetal sedation that can happen, and we don't want to ever assume, this was probably the most important point that I found in several articles that I read. We don't want to assume that minimal or absent variability is because of the magnesium administration. We always want to rule out any other possible causes. We still want to attempt our intrauterine resuscitative measures. We don't want to just look at a strip and say, oh yeah, she's on mag, it's fine. Because there may be underlying issues that we're not aware of at the time. So we want to be mindful of that. So the next medication on our list is metoprolol. And this can be given during pregnancy with caution for certain disorders such as valvular disease and dysfunction. In our maternal population, it lowers their heart rate, and the goal is to optimize cardiac output. For our fetal population, it does enter the fetal circulation, and it follows the beta blockade, which can lead to hypoglycemia and or bradycardia. So we want to watch for that bradycardia on our EFM when the mom is in labor. Our next medication is digoxin, commonly referred to as DIG. It is used to treat heart failure and certain arrhythmias like AFib, aflutter. There are no contraindications for use of digoxin during pregnancy and lactation. For monitoring, we want to monitor their serum digoxin levels and their electrolytes. We know that DIG is a great drug when used properly, but patients can become toxic, and that can become very dangerous. It can cause EKG changes, and telemetry is recommended for those patients. And this was a fun fact that I think I knew. I learned it way back in nursing school, but I just reminded myself when doing all this reading. Digoxin is actually derived from a plant. So I thought that was kind of neat. A lot of drugs are actually derived from plants. So fun fact, that's the plant there in the picture that it is derived from. So I thought that was interesting. So DIG toxicity, we mentioned that digoxin is generally safe for use in pregnancy and lactation. But what can happen is pregnancy physiology leads to changes in the bioavailability and the clearance of the digoxin, which then can actually lead to a reduced drug effect. So a normal dose in an adult population may not be effective during pregnancy, and therefore a pregnant person may need a higher dose, which then is putting them at risk for toxicity if we're not watching them closely. So our clinical signs and symptoms of toxicity include arrhythmias. So the patient would start to feel palpitations, they might be dizzy, they may have some dyspnea, or they may experience syncope. Vomiting is the most common symptom, and they might have visual symptoms. They have reported seeing green or yellow discolorations in their eyes. So that's interesting. It's probably a telltale sign. If they're seeing that, you definitely want to stop the medication and call your provider right away. And these are some of the references I used in doing my research. And there you have it. So feel free to provide any feedback, any thoughts that you have, and any additional topics that you want to hear more about or learn more about. I'm happy to present those to you. Thank you.